Good evening, everyone. It's good to see everyone. And just to let you know, this is the Early RAIA and Living with RAIA Support and Education Groups. I'm here with, I'm Joan Westrich, a social work coordinator of the Early RA group, here with Adina Batterman, who is a senior manager of Inflammatory Arthritis Support and Education Groups, as well as Nabila Baitori, who's the coordinator of our new Latinx RAIA Support and Education Program. We are delighted today to welcome our speaker, Dr. Jeffrey Ciccone, who is Assistant Attending Physician, Pain Management at Hospital for Special Surgery, Department of Anesthesiology, Critical Care, and Pain Management. In his practice, Dr. Ciccone treats a wide array of conditions with a focus on acute and chronic pain management, something that I know is of utmost importance to many people in the room. This evening's presentation is on interventional pain management for inflammatory arthritis, a multi-modal approach, and it draws on Dr. Ciccone's interest and clinical acumen in employing a holistic, multimodal approach to treating his patients in conjunction with physical therapy, lifestyle modification, and rehabilitative techniques. So without further ado, I turn the camera and the floor over to Dr. Jeffrey Ciccone.
Okay. Thank you, Joan, for the nice welcome, and Nabila for helping out, and Adina, thank you for inviting me to the group and talking about some things that maybe I could shed some light on. So the focus is obviously going to be on, where my field kind of help out and work in conjunction with your rheumatologists and other physicians in sort of treating the symptoms of inflammatory arthritis. As we say in my field, it takes a village to kind of help with a lot of different conditions, not just these. So, what I've developed over my training and kind of is more of the modern approach to pain management is what we call a multimodal approach, meaning we attack it from a lot of different sort of directions to control pain as best as possible. Okay, so my overview, just to go over everything I'm going to try and get through for all you guys for information is I'm going to go over a brief definition of pain and some of the subtypes of pain that we think about on a daily basis in my field and where it might fit into inflammatory arthritis and all its conditions. I am going to give a definition of what we mean by multimodal by kind of talking about everything we do. When is a good time to see a specialist like someone like me? After your rheumatologist, I'll go over that. And I do want to go over a lot of the different modalities that we have for pain control. And this basically is what sets us up for being in a multimodal paradigm. So we're going to go over some medical, meaning more medication treatments, interventional and procedural, which is a lot of what I do, rehabilitative, which is a little bit from the physical therapy standpoint, some different complementary options. And when I say options, they shouldn't be in lieu of things that we're all talking about here. That's why they're called complementary. They should go along with a lot of things we're doing or to try. And also some basic lifestyle changes. Okay, so what is pain? You might think it's a very easy definition, but it actually isn't. It's something that, every conscious or semi-conscious being might has some form of experience with it, and obviously someone with our conscious awareness has the most experience with it. So what it has been defined is there actually has been an International Association for the Study of Pain, and this is just comprised of a lot of different experts in the field of neurology and basic sciences and more of the clinical fields like what I do. Over the years, and we definitely have a lot of different societies for pain management as well. But in general, this was kind of talked about, a few decades ago to make an actual definition so we could actually treat it correctly. The main thing to understand is that there's a subjective and an objective component. So there's something we can definitely say, this is pain. And then there's a subjective component, meaning, well, what is the patient actually experiencing or the person actually experiencing? And it could be different for everybody. So the definition has been basically followed as this: an unpleasant sensory an emotional experience associated with actual or potential tissue damage or described as a result of such damage. So the first part of that is obviously some of the subjective. Everybody experiences these things differently, but the objective is the second part, that something actually has happened to the body or some sort of damage. Okay. And the thing on the bottom is a little complicated, but it's just to give you an idea of kind of all the whole rainbow of when you experience pain. These are kind of how it's gone through the body. Okay. So the sensory discriminative experience is the actual sensation that the body feels when you get a cut on the skin or break a bone or something like that. The motivational affective is sort of that initial reaction that you feel of the ouch, essentially. And there could be, for a lot of us, there is an emotional component to it, which is not wrong or bad or psychological. It's the natural reaction to it. And the cognitive evaluative is more of, how do we react to it once we've sort of processed the pain in our brain? Okay. And that's kind of where, a lot of where treatments come into and how how us physicians can kind of help out with that. Okay. So lots of different types of pain. And what we're going to focus on, for our talk with our group here is mostly the somatic and the acute versus chronic. Okay. So inflammatory arthritis pain is really a somatic type of pain. And what we mean by somatic type of pain is it's more in the, it's typically pain that is related to anything in the musculoskeletal system is always defined as somatic pain. Other types of pain is, pain from some sort of injury, sports injury, a different type of cut, something very traumatic. These are all types of somatic pain where it could be generalized pain, but it's also very localized pain, but we can put a particular sort of source for it where we know. Okay. And it's typically could be sharp pain, could be very achy pain, could be throbbing type of pain. These are kind of in the somatic realm of pain. So a lot of what is experienced in arthritis types of conditions and musculoskeletal conditions. Visceral pain is more pain, different things like abdominal pain that's more related to something going on in the colon or the gallbladder. It's a very different type of pain. Headache pain can even be sort of described viscerally sometimes. So we're not going to go into that too much. Neuropathic pain is usually pain that has a nerve component to it. Even if you don't have a nerve injury per se, sometimes pain can develop a neuropathic pain because the nervous system develops certain maladaptive or bad pathways that we shouldn't be doing. So we don't have control over that. And we're still trying to figure out with a lot of chronic pain syndromes that there might be this neuropathic or nerve component to it, even though the nerve wasn't damaged. So there might be some neuropathic pain that is related to inflammatory arthritis. So we'll talk about it a little bit. And then acute versus chronic is we do treat them differently. So acute pain is provoked by a specific injury, meaning you get a cut, you break a bone, you have surgery, you have some sort of trauma. And it usually has a biologic purpose, meaning the body's trying to tell you that something's wrong. When you cut yourself or you break your bone, the fact that you have pain means you're going to guard it and not do something with it, on purpose and hurt it more. So there's that is kind of part of a lot of biologic life. It improves usually after the cause is treated. I mean, these are very broad definitions. Okay. It doesn't always, obviously. There are a lot of kind of acute pains that take a while to kind of get over, even though we're treating it correctly and we treated the cause. But that's a general definition of acute. Chronic pain is typically defined by lasting more than 3 to 6 months in duration from an initial event. Okay. Sometimes we don't have the initial event. Obviously, in inflammatory conditions, there is no initial event. It's sort of things start over time and your autoimmune system starts acting up. But in general, it's at least 3 to 6 months in duration where you're feeling the symptoms of pain. So a lot of times chronic pain can stem from an acute injury. And then if it's not getting better, even though the initial event was treated, it can develop into chronic pain. And that's what we're still trying to figure out, why things develop into chronic pain. There's no general biologic purpose to chronic pain, meaning there's no adaptation that the body has had why we have chronic pain, or nothing we can think about. Usually the initial cause is treated. Obviously, there are a lot of misdiagnoses and why you still have chronic pain, but many times the initial cause was at least initially treated, but you still might have pain going on. And the latter, and sometimes the first, acute, may require multidisciplinary care, meaning from your primary doc, from your rheumatologist, from someone like me, from a surgeon, depending on what's going on, okay? And then a lot of chronic pain conditions, like inflammatory arthritis, can kind of be this track where you do have acute flare-ups, and then you get better with the flare-ups because we're treating the actual autoimmune disorder, but then you still kind of have the underlying chronic problem. So it could be an ebb and a flow between acute and chronic. There could be an acute on top of chronic. And that's kind of what we have to kind of help out and decide what the right thing to do is. Okay, so overview of pain management, current pain management in 2023. Pain is integral to every medical evaluation. When you're going into every doctor's office, they should be asking you, do you have pain? What's your pain scale? Even if you're not necessarily going in for a painful condition, because a lot of medical problems have a pain associated with it. So we are looking at this, or we should be, okay? It is part of sound medical practice. It is part of a standard of care to actually at least see why someone has pain, or send you to someone that has pain, or do at least basic treatment for pain, okay? The multimodal aspects of it. So all the ways we attack pain. There's medication, which we're going to go over. There's rehabilitative, which is your therapy and some of your physical activity, which is very important. And we care about that a lot at a hospital for special surgery, obviously. Interventional. Interventional could take a lot of different forms, okay? And this is kind of some of the stuff I do. There are nerve blocks, maybe not as important for inflammatory arthritis conditions. Steroid injections to different parts of the body, which are cortisone, which a lot of times we try and get over acute flare-ups with this. But there's also some chronic use for it, and it can be to a lot of different joints that are affected or different parts of the musculoskeletal system. Ablation is another technique I'll very basically go over for some very specific things. There are obviously minimally invasive surgeries and implants if the structure of a particular joint or soft tissue is in a certain, badly damaged enough that we might need to change it structurally, which was where those things would come in. Complementary, we'll go over things like yoga, acupuncture, a few other things, okay? And then obviously lifestyle changes can help. Obviously, lifestyle is not the only thing to do when you have a diagnosed illness like an autoimmune disorder or rheumatoid arthritis or psoriatic arthritis, but it can definitely, improve your baseline condition with certain changes. Okay, so acute versus chronic pain, to go over a little bit more. Chronic pain is usually more multifactorial than acute pain, okay? Chronic pain, and specifically because we're talking about musculoskeletal things, there's often a musculoskeletal component. There can be what develops into a neurologic component, and that's why we think chronic pain develops, that something's going on in the nervous system where different nerve endings are reconnecting in ways that are not supposed to happen, or not biologically, the right thing to happen for the body to adapt to it correctly. So we do think there is something going on there. And psychological, not to say that something's, it's in your head, but what happens is, when I mean psychological, chronic pain, there's usually changes in some of your neurotransmitters, and that can affect your mood, your emotions, everything else. And it can be a bad cycle that goes between pain and some psychological effects that happen. So it's part of it, and we have to kind of work through those things as well. And like I said, acute and chronic pain may require multimodal therapies, and specifically some chronic pain. Okay, when should you seek a pain specialist? When should you seek someone like me? So let me tell you what what my field consists of, and the type of docs who do it. Those four, specialties are typically the ones that are in the subspecialty of pain management and might subspecialize in it. The top two are usually the main ones that do it. And then there are a lot of neurology and interventional radiologists that do some specialization in it as well. So anesthesiology and physiatry and rehabilitative are kind of the main docs that do it. So meaning we're all trained in our primary fields, which are those, as you see, but we've all done a subspecialty to some extent in pain management, which is usually requires a fellowship. And we might be focusing on that like something I am, which is, for example, I don't do anesthesia anymore. I haven't done anesthesia in years, and this is what I do, okay? So when should you see a pain management specialist? So obviously it should, for our group that we're talking about here, it should be in discussion with your rheumatologist, which hopefully many have, or your primary care physician. And really, obviously, patients with a rheumatoid arthritis and all the subtypes of rheumatoid arthritis, typically are usually being treated with some sort of, infusion type of therapy, immune modulator type of medication. We have a lot out there right now. So really when you're coming to see me, it should be, when those basics are, when treating your arthritic condition, because we know the underlying disorder, when your symptoms are not fully controlled with it. Even if your markers can be down, meaning I know a lot of times where we say, well, you're responding to the infusion or just giving an example, something like Humira or things like that. There are different markers that your rheumatologist is looking at in the blood tests, and your inflammatory markers can be down, but you still might have pain. So that is definitely some time when you should come in and see us, because we're kind of treating a lot of symptoms, okay? Initial treatments. So, which usually consist of the basic medications like we're talking about, the autoimmune medications, exercises, lifestyle. So when these things are not improving your pain, okay, even if some of the objective things like your markers are down and stuff like that. And like I said, when the autoimmune medications are not working, that's also something, obviously we have to look for other things to sort of treat the autoimmune disorder, but there might be some things we can help out the rheumatologist with as well. Okay, so let's start going over some of the multimodal therapies, okay? We'll start out with some medications. There's a lot of different classes of medications. I've tried to put some of the ones that we've focused on for someone with a rheumatoid arthritis type of condition, what our main things would be using. I'm not going to go into autoimmune therapies. There's a lot of different ones that are getting tried right now. Obviously, that's more with your rheumatologist, and I would have to ask them, maybe some specific things, because new ones are coming out all the time. So the general categories that we use for this are anti-inflammatory, something like, NSAIDs we'll go over, corticosteroids, both oral and interventional techniques with it, some neuropathic medications, and, even though you don't have seizures, we'll go into it. They're originally anti-seizure medications for any nerve-related pain. I will briefly go over opioids or painkillers or narcotics, and then antidepressants, even if you don't have any sort of mood issue or emotional thing or depression, we do use antidepressants to treat some type of pain, because there is a neurotransmitter type of situation going on in a lot of different chronic pain syndromes. Okay, so I know this is a complicated thing, but this is sort of the simplest way of looking at the inflammatory cascade. But the point is, there's a lot of stuff going on here in an inflammatory cascade, whether you have regular arthritis or one of the inflammatory arthritis, or when you just have even simple tissue injury, this is what's going on, okay? So these are some of your basic things. I'm trying not to use brand names because I, don't, have any money from any pain companies or anything like that. So some of these, if you have questions about them at the end, which ones are this, but I'm sure a lot of people on this talk might have tried some of these, but ibuprofen, naproxen, those are your basics, Motrin, Aleve, Advils, things like that, just so you're familiar with it. Celecoxib is Celebrex, diclofenac is Voltaren, Meloxicam is Mobic. There are other ones. These are the typical common ones, okay, that we use. Next slide. Okay, so, and I'll get to why, but for acute pain treatment, regardless of the cause, but typically for any musculoskeletal condition, whether it's an injury or an inflammatory arthritis, you haven't taken anything before, you haven't done anything, it's usually a first line thing, okay, to at least try, as long as you can take it, secondary to any side effects or problems that you might have medically where you cannot take it. They can be used for intermittently for chronic pain, okay? We don't say, why we say intermittent, because based on what I said from the back, it's because of these side effects and contraindications, and showed a little bit on the last slide with that. Chronic use of NSAIDs, meaning daily use all the time, can cause a lot of different issues, okay? Cause a lot of GI issues, as most of you probably know. We can get ulcers, a lot of issues in the stomach. because it changes the gastric protection there. Over a long time, it can reduce your kidney function. And that's kind of like the main problem why, using them chronically for months to years and end on end, eventually it can affect the kidneys. Coronary, if you have coronary problems, if there is a history, there is a slight increased risk with that, okay? Because we know now with coronary artery disease, there's something with the inflammatory cascade that's related to it. And obviously, if you have bleeding issues, these could increase any sort of bleeding. If you don't have bleeding issues and you're not on any blood thinners or anticoagulants, it's not really a issue to be concerned about with bleeding. Acetaminophen, I want to break up and I'm bringing it up in here because a lot of people think it's like an anti-inflammatory, but it's actually its own medication, and we don't have another class for it. But honestly, it's definitely something that, as long as you're allowed to take it and your liver is okay, it's definitely something to think about to add to any sort of, regimens that we're talking about with other medications. It is an unknown mechanism, surprisingly. We really don't have an exact cell mechanism for it. What we do know is it acts on the thalamus in your brain, which is a big kind of central processing unit in your brain. Antipyretic means that it brings down fever, so it does something to the temperature regulation of the body. And it does have a lot of anti-inflammatory effects, meaning it affects that cascade where we were coming in here, but a separate part of where the NSAIDs come. Again, another mainstay in acute pain. It is useful in chronic as a synergy with other medications. Total max dosage is 4 grams in 24 hours. Okay, that is the thing. If you start going over that, that is when you could really have a serious liver issue where you can actually go into liver failure. So that's a lot of Tylenol. More recently, though, we are all recommending to not do more than 3,000 milligrams because we realize everybody's liver processes things differently. So 3,000 is usually a generally safe number. There'll even some docs that are going to say, no more than 2,000. I think that's a little conservative, especially if it's helping you and you could use it in conjunction with your other things. But this is kind of where we look at it. There's liver toxicity. We definitely reduce it in older people, liver dysfunction, or any other toxic medications that might be affecting the liver as well. Okay, corticosteroids. These are your cortisones, okay? Medication. You could take oral steroids, which I'm sure a lot of people have had for, acute flare-ups of their rheumatoid arthritis to get you, over that hump, okay? And it's definitely something that's managed with the rheumatologist. Injectable is a lot of what I'll talk about a little bit later on because it's basically our mainstay for our procedural type of interventions that we do. And what the whole point is to give a targeted type of, steroid anti-inflammatory to where, the worst pain is to get over acute flare-up instead of trying to get it all systemically, okay? So, when we're talking about oral, though, it does require careful tapering in conjunction with other rheumatologic agents, meaning you can't be on steroids forever. It could affect your adrenal glands. It could affect a lot of other things. It could affect bone density. So it needs to be, used for usually a certain amount of time, could be on it for a while. Some cases, a lot of patients have to be on it for a while. But it has to have a lot of different management so we're not, causing problems in those other parts of the body. Okay, so anti-neuropathic and anti-seizure medication. I'm just really going to go over these briefly. I'm sure you've might have heard of these or been on some of these. Gabapentin is Neurontin, pregabalin is Lyrica, Topamax is the other one, and Keppra is the other. We usually use these for other types of nerve pain, but if you're having chronic pain, there might be a neurologic component to it where the nerve endings have kind of changed how they fire. So we do try and use this, and it could potentially reduce any sort of inflammation from like a nervous system standpoint, because the nervous system still controls inflammation to some extent, okay? It's not generally effective in acute pain because the problem with these medications is you have to be on them for them to work. They're not used as needed like some of these other things we're talking about. We also use them in preventing severe acute pain post-operatively. So if you are having a surgery for your joint or something like that, sometimes we use them and it can reduce your pain afterwards, meaning what your pain is going to be like after the surgery, okay? They may reduce your baseline pain if there's some nervous system issues going on, okay? Some of the side effects can be, as I've said below, kind of the common things, but blurry vision, swelling, it is cosmetic, can cause balance issues, they can cause dizziness. So it does require a careful sort of looking at things, okay? and management by someone like me or a rheumatologist or your, primary care doc. Okay, opioids, just to go over them. These are all your oxycodones, your hydrocodone, your morphines, tramadol, codeine. Hydromorphone is Dilaudid if you've ever had it. Okay. So obviously, these are big things in the media over the last decade, even. It's a major focus of, medical debate, whether, how much we should be using these or how long you should be on them. And there's a lot of political and economic issues surrounding them as well. And it's for the reasons we'll go into below. They are standard for acute but severe pain, and meaning post-operatively, trauma, fracture, major injury, obviously in terminal and cancer patients. These are a standard of care. Okay, so they do have a significant role. And they may have a significant role in acute flare-ups of an inflammatory arthritis, particularly for us if we need to. And when I mean, for a very short term, meaning a few days, if that's what it needs to be, okay, to maybe help get over it. Okay. Chronically, though, in recent years, it has been found to be detrimental, and that's why we kind of have a lot of regulations surrounding these. Okay, for a lot of different reasons, they have increased morbidity and mortality for a lot of different problems, whether you have other medical issues or don't. There've been a direct association with increased mortality because of opioids, and it's not necessarily because people get addicted or overdose. They can interact with a lot of different other medications people are on. They could cause a lot of different problems, and this is when it's chronically used. Okay. They do suppress the immune system. And I know with rheumatoid arthritis, well, it's like, well, hey, shouldn't we suppress the immune system? It's not in the good way, meaning it could make you prone to infections when you're using them chronically. Okay. I do want to point out the difference between dependence versus addiction. Okay. Dependence, a lot of people can become dependent on them, but that doesn't mean there's an addiction. Dependence means your body gets used to it, meaning physically that you can't not function well without them. Okay. That doesn't mean addiction. Addiction means is a specific diagnosis when they have a significant bad effect on your daily life, where you're having problems in your life because of you using these, and you're starting to use these not for the original medical condition that you have been, treated with in the first place. The problem is with these medications, even if you don't have addiction or those problems, there can be a development, because we do know now with use of these over the years that it can change your brain chemistry in such a way where you can become addicted. And that's a lot of work that's going on right now in different fields where, how can we predict who can get addicted and who won't? Because if we have a good prediction of who won't get addicted, maybe we will use these a little bit, maybe there is a little bit more role for it in those patients. So something that's being worked on. Okay. There is a certain thing where we've seen increased pain with opioids as well, and that's in chronic use. Okay. Okay. Side effects, a lot of side effects that can happen, but a lot of those side effects can be tolerated over time. The bad complications are right there: the respiratory arrest, the sedation, the confusion, the addiction. I don't want to go into that too much because that's not, the common things, but it's things that we get really nervous about, and we don't have those types of severe complications with a lot of other treatments we do. So we do take, a lot of weight when we're talking about opioids, and if we're going to prescribe or think it's a good idea to do it. Addiction rate can potentially be up to 15 to 20% in chronic use when you're starting to use these over an 8-month period. That's been in studies. Okay. It's a general thing. So we don't take it lightly when we want to say, and this has been coming out over the last, decade where we've seen this. It takes time to see these things. All the major pain societies do not recommend use for greater than 6 to 8 months for benign pain syndromes, meaning non-terminal syndromes. Okay. Which is most things. And the CDC does have significant guidelines on these, where it is recommended to limit the maximum daily dosage for chronic use. And it does require intense monitoring. Okay. Like meaning monthly visits, making sure things are going okay on these. So it does require a lot of intensive care, to be on these chronic. Okay. Antidepressants, very briefly, not as much in a role of, in the inflammatory arthritis, but Some antidepressants have an effect on the neurologic component of pain, and meaning the neurotransmitters. And the three I've put up here are specifically the ones that I'm talking about. Okay. Other antidepressants typically don't treat pain. Okay. These can actually treat pain and are almost primarily used for pain at this point and not for other things like antidepressant effects. Okay. And the way we think it helps is it somehow reduces inflammation from a central nervous system approach, meaning it changes the neurotransmitters going to the muscles. And then what happens is the muscles or the tendons or the joints, they kind of, the inflammatory cascade that I was talking about before kind of decreases a little bit. Okay. Again, not useful in acute flare-ups, might be useful in more chronic syndromes. Okay. Side effects are similar to the ones we talked about for the anti-seizure meds. Okay. I want to go over this because these are kind of our general steps. The World Health Organization a few decades back has put out a ladder of pain when pain was starting to say, in modern medicine, we have to start treating pain. And there's different ladders for terminal and cancer pain and non-cancer pain. So I'm going to go with these with the non-cancer pain or the non-terminal pain. And there are variations of this if you look this up, okay? But as you can see, if you go step 1 to step 2, step 3 to step 4, step 1 really starts off with, very basic analgesics like we're talking about here. Step 2 might consider a weak opioid analgesic, but usually this is like when we have like an acute flare-up, okay? Step 3 is when we start to think the minimally invasive interventions, like some of the injections and things like that, okay? Now, again, this isn't putting in like some of your rheumatologic medications, but this is kind of generalized, chronic pain. And then step 4 is when we really start to bring out the big guns, so to speak, okay? When we're really kind of at, as long as the candidate is good to be on something like opioids, okay? And then this one I put up here, this integrative medicine therapy is sort of what we're talking about with the multimodal stuff. Like I said, there's a lot of variations. So we have to kind of think about all these other things to go into it with this step and not just medications. Okay. So interventional, procedural, a lot of what I do. These are, and I'm going to go over very basics of it. There's a lot of different things we try and do to bring down acute pain and bring it down to more of a baseline level of pain. We do a lot of joint injections. Your rheumatologist probably does as well. These are things that go straight into the joint, okay? Typically, we do it in the hip, the knee, the shoulder, some small joints. Some of the surgeons are very good at doing stuff in the hands and the fingers if it's appropriate. And also the sacroiliac joint is something that joins the pelvis and the hip and the lower back, which is a major joint that's affected in all the rheumatoid arthritis. And sometimes that's how we even diagnose on films that someone might have a rheumatoid arthritis or psoriatic arthritis or some sort of other spondyloarthritis, okay? So sacroiliac joint is something that really comes up a lot. Spine, which is kind of my major specialty. The inflammatory arthritis can affect every joint in the spine, meaning cervical in the neck, thoracic in the mid-back, and lumbar. So all the way from head to pelvis, okay? Sometimes we do epidural steroid injections. I'm going to get to the more common thing we think about in the arthritis type of conditions, okay? Epidural steroid injections usually when there's a nerve component or nerve pinching, okay? Trigger point injections are usually temporary type of things that we inject in the muscle or the fascia, which are the layers between the muscle. Muscles get under a lot of tension under inflammatory arthritis, okay? So sometimes we just need to kind of cool off the muscle and that kind of gets you over the hump, so we can do trigger point injections. I'm sure many of you might have heard of hyaluronic acid injections or the quote unquote the gel injection, okay? And that's typically for a few major joints. Usually that's when there's also a major structural problem that's going on as well on top of the inflammatory arthritis, meaning that you have less cartilage sort of going on there. It's not just the autoimmune thing in inflammatory arthritis. And what that can do is kind of, it doesn't really recreate cushion in there, but it acts as a cushion temporarily. And when they work well, they can last at least 6 months to a year or even longer. Okay, so it's another different thing on top of the steroids we can think about. Facet injections in the spine is something I do a lot of. Okay, every level of your spine has something called a facet joint, a facet joint, depending on how you want to pronounce it. There's been different ways it's pronounced. They're in the cervical spine, they're in the thoracic spine, they're in the lumbar spine, and they're at every single level of the spine. There's one on each side. Okay, so very tiny. We think a lot of typical back pain that is coming from the spine, but if there's no nerve component to it, we think a lot of that pain is generated by these facets in my field. And specifically in inflammatory arthritis, we think a lot of these joints are affected. Even if we do imaging and it doesn't show anything, we know in inflammatory arthritis, you have a metabolic thing going on, and these joints are getting attacked by your immune system. And maybe there's ways we can calm it down. So it's something, I'm going to show you some pictures of what we think about, and it could be something to think about. Radiofrequency ablation is something we do on these facets, okay? This isn't a surgery. It's still a type of injection where what we kind of do is scramble the little sensation nerve endings that go to these joints, and we could have longer lasting pain relief. Again, it doesn't treat the underlying inflammatory arthritis, but it can significantly help manage some symptom control. And this is kind of where the multimodal thing comes in while you're on the Humira, while you're on this or other things. If you're having these flare-ups, then we need to kind of calm things down for as much of a time as possible. Okay. Interventions, just to go over, joint injections, they're very, very low risk of complication. We're not really worried about a lot of things that happen. I mean, it could be a little bit, uncomfortable sometimes to be done, but in terms of medical complication, only things that really is very, very rare chance of infection or bleeding in a joint or anything like that. Okay. And these are done under sterile conditions. So, infection is low. Spine, we do a lot of them. Obviously, if it's something we would talk about in more detail if, with your physician, or if you go to see a pain physician that's doing these. A nerve or spine injury is extremely rare in these types of injections. Okay. We're not talking about surgery on these. Okay. Just want to go over some of the basic side effects of steroids or cortisone when we do these injections, either in the joint or the spine or the soft tissue. Okay. People can get a little insomnia the first few nights. Steroids can kind of make you a little hyper sometimes for some people. It could increase your blood glucose. So if you do have diabetes also, it's something you do have to, be wary of, and we have to be, cognizant of that. You could get facial flushing. It's not dangerous, but people don't like the way it looks. So if you got an event to go to in the few days after you're getting one of these injections, maybe we should hold off on doing it, or, until after an event, if you have any sort of cosmetic thing you want to look at. Weight gain is something that people ask me about. It's very temporary. Okay. I'm not talking about oral steroids that you're taking, if you have to take them for a certain amount of time, that could definitely cause weight gain. A simple one-time injection, or on occasion, there could be some very temporary weight gain, but not anything chronically. Okay, so it's not something to think about. Everybody's going to always ask me about the lifetime limit of steroid injections. And, there is no extreme lifetime limit. What we look at is what a trend is, when you're getting steroid injections. There is a note of when you're getting too many, because it can cause all these other problems. It could affect your adrenal glands and how you naturally process your own steroids that you make. But, if they are overutilized over time, meaning, and there's no right number, it's just sort of, if you're on oral steroids a bunch and then you're off of them, and then you get 3 injections, and then, the next year you're on steroids again. And it could be a lot. Okay. But on occasion, these are okay to do. And what I mean by overutilized, it can lead to low bone density. There is, a limit on it. It can lead to osteoporosis. That's with the oral steroids as well. We all know that. And they obviously do immunosuppression. That's the whole point in using them into an autoimmune disorder. But the other problems with immunosuppression can come with that. Okay, just very basic pictures of spine interventions. On the left is an epidural cortisone injection, if you've ever wanted to see what it looks like, okay? Obviously, there's a lot of anatomy involved in that, but that is something that we do as an outpatient, and that's to kind of highlight where the nerve root, if there's a disc herniated, and where we're putting the steroid. The one on the right, if you can kind of tell, that's like a little joint. That's what I'm talking about as a facet joint. You have one on the other side, and you have one at every single level going up and down the spine. Go right into the joint and right near the joint to try and give a little bit of treatment to that when it's appropriate. Okay, minimally invasive versus surgical. Basically, the difference is there's a whole spectrum. Minimally invasive means, how much trauma are we doing on the body from the procedure? A needle stick versus an incision and implanting things or having hardware. That's the most invasive, right? There are different minimally invasive surgeries that are out there if you also have kind of overlying spine problems, half because of the rheumatoid arthritis, but that might, or the spondyloarthropathy that, some people are diagnosed with, can affect the structure. So there might be different things we could do to change the structure. Some of these are done by some surgeons. Some of these are done by some docs like me. There are things called spinal cord stimulators and peripheral nerve stimulators. Even if there's not a nerve problem, sometimes we put these in if the pain is so severe that we're trying to control it from the nervous system standpoint, if all other kind of things have been exhausted, all other treatments, okay? And then obviously there are surgeries for the spine, decompressions, fusions, reconstructions if things are bad enough structurally. And we all know about joint replacements, I mean, especially at this hospital. And a lot of times that might be the answer, if we've gone through a lot of different things, okay? Okay, rehabilitative. This is your PT. This is your physical therapy. Well, I obviously, physical therapy, you can't be going to the physical therapist every day or every week for the rest of your life. But the point is, a lot of times what we're doing with rehabilitative, it can be after acute flare-ups on top of chronic things because something new has happened or something else is going on, meaning you're having an imbalance in one of your gluteal muscles that's like kind of throwing your spine off, or you're having an imbalance in your quadriceps muscle versus your hamstrings, and it's throwing your hip off, and you also already have sort of rheumatoid arthritis that's affecting your hip. That's where this needs to come into play, and it's very important. And what you learn at, in your rehabilitation with physical therapists or an occupational therapist is, how are we trying to maintain your function around a joint or muscle group? And you have to continue that on your own. And I know it's hard, but doing that will actually help control pain. So there is a little bit of an element of fighting through pain, not severe pain, but there is a little bit of that element of fighting through some pain might be the right answer. Okay. And even if you're not having pain, this is definitely something you still need to do. And the goal is to always improve your flexibility around a joint, strength, but it needs to be maintained with an HEP. And HEP is that home exercise, regimen. Okay. The home exercise program, whether it be stretching, light weights, walking, basic jogging. There's a lot of different things. Everybody's different and everything's going to be differently tailored for people. And it's integral to every action plan for pain from the musculoskeletal system. And then, a lot of times, the whole point of rehabilitative is sometimes to treat the root cause of what's going on, and sometimes the way we have to figure it out is, okay, this muscle group is not strong enough. And that's why your arthritic joint is having all these problems on top of what you have, why you're having more pain, is because the muscles around it are not strong enough. So that's what we're doing with rehabilitative medicine. Okay, complementary. Just very basically, acupuncture is definitely something that is very, very low risk and is something to think about, to undertake in terms of joining it with everything I've been talking about. We don't have an exact mechanism of why acupuncture can or, it may not work, but why it can work. What we do know it does biologically, it does improve blood flow to the affected areas that it's supposed to be treated during acupuncture. Anytime you improve blood flow is generally a good thing. Okay, so that's something to think about. We do know it also decreases pain neurotransmission on a kind of general level. It can decrease some of those neurotransmitters that are affected with a pain response over time. So this has been shown scientifically. So it's something to think about with acupuncture. Yoga has been shown to improve pain when done in certain circumstances. We're not talking about advanced yoga that, if you're having, different structural issues in your spine or your joints, may not be the best thing to do, but very basic yoga, we know improves flexibility. We know it actually improves blood flow. It actually improves some neurotransmission in the periphery, in the musculoskeletal system. So if it's something that can be undertaken, it might really help out a lot for a lot of different things. We don't have exact science on it, but we do know there's a good relationship. Meditation, someone's always asking about that. And we do have a body of evidence that if we can sort of control certain things in the nervous system through meditation, we actually can sort of change a little bit of the inflammatory cascade, sort of similar to what we're talking about with the medications, okay? But this is sort of, maybe we might be able to change some of those nerve pathways that might lead to more inflammation. So definitely something to think about if you haven't employed before. It should be sort of part of, a lot of different treatment regimens. I just put down stress in the nervous system because stress in the nervous system is kind of the basis of a lot of times why we're feeling a lot of different things, or why we're getting, not necessarily always when we're getting flare-ups of pain or certain things, but why pain is lasting longer than it should. Some of it is because of this, and some of these things can kind of bring that down. Okay, cannabis. I know it's a hot topic in the medical field. There's different trains, different bodies that say the benefits are great, and then there's other people that say the risks are too great. We're probably somewhere in between. Okay. In general, we know it is probably, safe as long as you're not having a lot of other sort of medical problems where cannabis can affect. And I'll go into that very briefly. Okay. What we do know is we know there are receptors in the body that are called cannabinoid receptors. There are natural receptors in the body that, that this molecule, kind of latches onto. Okay. And it's in soft tissue. It's in the nerve. When I say neural interfaces, I'm talking about when the nerve is connected to the muscle at the end of the nerve. So not as much in the brain, but there are that in the brain. And these receptors are implicated in some of the pain response amongst all the other receptors we're talking about in inflammation in the nervous system and other things. Okay. So that's why, we think it can possibly help. Just to give my basic knowledge of it, it's approved in New York for chronic pain conditions, okay, from anything, including inflammatory arthritis. Things like multiple sclerosis is approved for, headache syndromes is approved for, anxiety and PTSD, okay? It is now also legal for recreational use in New York. New York, though, still hasn't set up the infrastructure yet for you to be able to get it necessarily recreationally, or you can, but a lot of places where you can get cannabis are still requiring you to have sort of that medical license for it right now, okay? That medical license doesn't necessarily mean, at this point where, you're getting sort of a special type of cannabis that's only for medical things. That's how that's marketed. That's not really how it works. We don't really know what strains work for what with pain. There's no studies on that. Any studies that are out there, they're not good science, okay? And leading into, I want to write federal versus state. I don't think it's such a big deal, but it is kind of an odd thing with our country. It is still completely federally illegal to use this substance for anybody. It's technically federally illegal for a doctor to even prescribe it to you, okay? So how that makes sense, I don't know. I'm not a politician. I'm not into law. I don't understand how it makes sense. But then half the states, it is completely legalized on the state level. So be that as it may, this is what we do not know. We don't have any true scientific evidence like we do for some of the other stuff that I've talked about to say it works or it doesn't. Okay. It can work, cannot work. We don't really have a good sense. Okay. I think part of the problem is we can't really study it very well because of legal ramifications because of that federal problem. Major groups, there can't be major, there is some NIH funding coming out, but there has to be a lot of issues, related to that. A lot of places can't get the real funding they need to do true studies on it. Okay. And that requires a lot. So that's kind of why we don't have great, science with it right now. We don't know if there's differences really from a strict medical clinical standpoint between different strains, or if they have different clinical differences, if this helps for sleep, if this helps for pain, if this helps for other things. We don't really know. There's a subjective sense that people that are involved in this, or the pharmaceutical industry that is involved with this, or pharmacists that are involved with this, there are some, it's more anecdotal. This affects sleep more, this affects pain more, but we really don't have any good reason to say one versus the other. One form versus the other are more effective. We don't know. oral versus inhaled versus topical creams versus sublingual, we consider a dealer's choice if you're going to try it. What do you think might be the best form for you? That's really, the best way, of thinking about it, or what makes the most sense right now till we get more science behind it. The risk benefit, the benefit, it's either, anybody who asks me about it, I typically say, the benefit could be there, or it could do nothing and you get some side effects, which, if you're not taking it, then the side effects go away. If you do have cardiopulmonary, so heart or lung issues, it is something you really should probably avoid. We know it does do stuff on the lungs and the heart in bad circumstances. If you only have minor issues with that, it's probably okay. But, it's definitely something you have to think about. Talk to your cardiologist, your pulmonary, or your primary doc, or your rheumatologist. It's something that has to be discussed if you have cardiopulmonary issues. The way you get medical usage license, there are certified practitioners, either nurse practitioners or some doctors, and they have to be certified in New York State to get that. Okay. Lifestyle. I put this up here and it kind of goes with the rehabilitative. Whatever the home exercise program that works for you or that you can do, I said it 3 times, it's the main part of lifestyle. Whether it's modification or not, it needs to be part of every chronic musculoskeletal condition lifestyle. If that is just walking around the block every day, because that's all you can do, then that's what we should do. Okay. It's going to be different for everybody, but not doing that, if you can do it, will make your pain worse, will make your condition worse. Okay. Diet modification, I'm not a nutritionist, but some basic things to consider. There are plenty of things out there that are considered anti-inflammatory diets. Okay. Red meats, things like that. It's kind of the typical things, but, getting something more tailored might help a lot of people with inflammatory arthritis. In general, I do tell some patients to avoid what's called nightshade vegetables, things like eggplant, peppers. You might like them. They are healthy. It's not causing a problem, but some of these vegetables have been implicated in a little bit of turning up the, overall inflammation of the body. Okay. Can make things worse. Tomatoes are in there as well. Okay. Not saying not to eat them at all. Okay. But if your diet's heavy in them, maybe consider switching around a little bit to something else, because it might make a difference. Okay. Turmeric is always something that's asked to me. And, I specifically bring that one up as a extra thing. This could even be in the complementary side of things. There is evidence, some mild scientific evidence for its anti-inflammatory effects. And it's specifically with daily supplements of anywhere from 500 to 2,000 milligrams. What number it is, it's in the bag. It's a range. Point is, when you're looking, or if you're going to GNC or getting something at, the drugstore where there's a supplement, if you're thinking about wanting to do it, it should be somewhere in this range. And then it really does have to be taken over time. It is a subtle thing, but overall it can kind of give you a lower baseline of the basic inflammatory cascade we were talking about. Okay. Obviously the 8 grams, the 8,000 milligrams is nowhere close to that 2,000, but we do know at that level, it is a toxic substance. There has been stories, anecdotally, you might have read in the news a few years ago, there was some craziness in California that there was some holistic practitioner, not a medical practitioner, not even a physical therapist, had no real degree in anything, but they were doing turmeric infusions into someone in the IV, getting into these doses, and some people died. Okay. So, I don't want anybody to, and I don't think anybody on this call is really into that type of stuff. I know we're a very educated group here, but when you hear about those things, just be wary. So, everything has some sort of a limit to it. Okay. But I definitely think it's something to think about as part of your lifestyle, as there's very little side effects with it. So, something to think about. And I keep it to like I'm saying, the oral forms of it. Right. Okay. Oh yeah. Potential future. And ongoing right now. Okay. Ketamine therapy. Some on this call might have already undergone some ketamine therapy. It is an anesthetic that I've used in the operating room. We do know it has some pain control properties, and at what we call sub-anesthetic doses, very, very low doses, as an outpatient, it can sort of help modulate some of these nerve endings that are implicated in pain. Can help, can have a lot of side effects. There's a lot of science going into it where it might be having some benefit, like objectively, and kind of reducing overall pain over some time. So there's definitely something to think about. Some things that are being worked on that are not anywhere there yet, but are worked on by some of the pharmaceutical companies. More selective opioids is something that not just for inflammatory arthritis and what we're talking about here, but would affect my whole field, would affect life in general. Okay, meaning selective opioids that don't have all those other effects, the addiction, the problems, all the problems associated with it. Okay, and more selective NSAIDs. We can find an anti-inflammatory, like make a Motrin, that doesn't affect the kidney or the stomach or the heart. That's going to be a pretty big deal for medicine in general. So these things are worked on. That's the potential future. Spinal cord and peripheral stimulation that I briefly touched upon. It's not the future because we kind of do them a lot now for a lot of different conditions, but we are starting to do a little bit more studies in applying these therapies to non-nervous system type of pain conditions. Okay, so that might be down the block where we might see some decent indications for things like, inflammatory arthritis. And that's something that's in my field that I deal with a lot. And that's all I got. That's everything.